Just wanted to do a couple of things before we go on for questions. I really have two things. In other words, as we listen to smallpox, measles, it sort of sounds easy. Well, it wasn't. And one of my challenges for the next few minutes is to challenge you and show you what the real problems were. I entitled this part of this The Legacies of Smallpox, Measles, and I could have chosen a lot. But I've decided to limit it to two. One, the global eradication of smallpox, and the second is the expanded program and immunization. 1974, the end of smallpox, measles program in West Africa. Smallpox was still endemic in in Ethiopia, Somalia, India, Afghanistan, Bangladesh. If this is the history of smallpox in India, which from a global point of view was massive, and if we take a really generous surveillance reporting rate of 5%, that's somewhere in the range of 2 to 5 million cases of smallpox. And as surveillance improved, always when the numbers went up, we blamed it on improved surveillance, and it wasn't always that way. One of the important things that developed after West Africa was really the house-to-house search, where people went door to door, showed a picture of smallpox, announced the reward, and I think the first search in UP found 10,000 unreported cases of smallpox. So the searches were extremely important. I want to share just a little bit of data from my own experience in Bangladesh. They had civil war, 10 million people left the country. One of the camps, or two of the camps in West Bengal got infected. The diagnosis was made here at CDC on the CNN News when they saw cases of smallpox. They loaded small cases of smallpox and susceptibles onto boats and to trucks, and smallpox spread like wildfire. Now I want to, can I have the lights down, please? Each one of these dots represents a smallpox-infected village. And I just want to go through in about 2 minutes 2 years of smallpox. Thank you. Each one of these dots: December 73, February 74, I've got every 2 months, April 74, smallpox is a seasonal disease with greatest spread in the spring. June looked better. August, pretty good. October, we had 89 infected villages. I predicted to the press that we would be free, and these two areas at the top were totally flooded out with the worst floods in 50 years, and they went into motion. December 74, February 75, April 75. We went from 89 infected villages in October to 1,500 the following May. June was better. We increased the sensitivity of surveillance. Got down to October. I went to the office on Sunday morning, 3 cables, one from WHO, congratulations, one from CDC, good job, and one from the Bay of Bengal. We have a case of smallpox. One of the keys was the reward for reporting a smallpox. And one of the major lessons that I'd like to share with you is learning from our mistakes. In Bangladesh, we started with a single reward, and we found that the public didn't know about the reward because the health workers wouldn't tell the public about the reward, and only after, as you can see on the graph, only about 30% of the population knew the reward. We learned that that was a mistake. We doubled the reward to pay both the first person reporting and the health worker, and we got to the point where about 85% knew about the reward. House-to-house search, Bangladesh, we had 10,000 workers Each one could search 1,200 houses. In 5 days, we could visit 12 million houses, and when we assessed them, we found that 89% of the houses in Bangladesh had been searched. Leo mentioned the sensitivity of surveillance. At the end of smallpox in Bangladesh, we did a survey of 400,000 people for scars, and then we interviewed them to get their history. We corrected for mortality and scar loss. And you can see in 72, we only knew of 10 of 70,000 cases. 73, it got a little better. 74 and 75, much better. So that the use of data, the monthly meetings, was important. Containment was also important. And again, I'd like to stress learning from failures. At the bottom here on the red is if you do everything else, everything right in a smallpox-infected village, there should be no cases after one incubation period, 14 days. And when we started looking, 25% of our villages had cases after 2 weeks. People were getting hungry, going to market, getting water. So as we sought out the problems and solved them, we each got down. And then we came to a point where India was free, and I was talking to Sabur along the India border, and I said, Sabur, how many outbreaks do you have? And Sabur said 17. And I said, how many went more than 2 weeks? 11. And that was a disaster, because they could have walked the cases across the border and got thousands and thousands of rupees. And I said, what are you doing? And Sabur said to me, I'm doing everything the book said. I'm putting the patient in the house, I'm isolating him, I'm getting a list of visitors, I'm vaccinating everybody in a half mile, searching everybody in 5 miles. And then over a cup of tea, a smile. But today I found out why. I am going into a house and asking for a list of visitors. They are not giving me the names of relatives who came to visit because they didn't consider relatives as visitors. So based on his observation, we added a list of relatives and solved the problem. But the key message for all of you here is that we provided a field worker with criteria to judge his or her own performance. And he asked the question why and came up with the answer. The other is the expanded program of immunization. Took me a while to get this picture, Rafe. I thought I would not be biased. I went to Google, and I'd like to read what it says about, as director of WHO's expanded program on immunization from 78 to 89, Dr. Henderson was the architect of the global effort that raised immunization rates from 5% around 1977 to 80% in 1990. In a public health career spanning more than 30 years, much of it with the U.S. Public Health Service, Dr. Henderson previously made contributions to smallpox eradication and the control of venereal diseases. The appointment of Rafe to EPI is an interesting story. They asked for somebody from CDC, and Dave Sensor flew to Geneva and sat down with Mala, and he said, I got this guy, Rafe Henderson. He said, another Henderson? I don't want him. And after that, Rafe served as Assistant Director General of WHO. And I met him the first week there, and he cleaned up all his work in the first hour. And he said, I can't even go to the bathroom because I got a bathroom in my office. Anyway, Rafe's priorities in EPI show what management is. He had a policy group which set policy. They worked on vaccine standards, production, distribution, stability, and financing. He had a unit for cold chain logistics and injection safety, a lot of management training for mid-level, and the assessment of coverage surveys developed in West Africa, monitoring program reviews and evaluations, and surveillance and disease reduction targets. I tried to find 2 slides that sort of capture what Rafe was able to achieve with his colleagues at WHO and at the country level. And I think this probably does it as well. You can see the increase in vaccination coverage, some differences by region, but a major increase globally. But probably more important has been the disease reduction targets. We'll be talking about two of the other diseases later on.